Good evening, everyone. I want to welcome you all to this year's second presentation of our 2023 Evening Speaker Series event. I wanted to thank our valuable industry partners for joining our event, and the Nebraska Oncology Society would not be able to meet its mission without their partnership. Here is our agenda for tonight. We'll go over just a couple of housekeeping items. Please keep your cell phones muted throughout the event. After our presentation, we'll have time for questions, so feel free to speak with our presenter. The event is being recorded and will be uploaded to the event website at a later date. And then just our disclosure and accreditation statement. Sorry, you guys can't see the whole thing. And for our event tonight, we are hosting a virtual presentation by Dr. Jeremy Calais. Dr. Calais is an associate professor of nuclear medicine and theranostics in the Department of Molecular and Medical Pharmacology at the University of California, Los Angeles. He is the director of the UCLA Theranostics program and the director of the clinical research program of the Amundsen Translational Theranostics Division. He is also a faculty member of the Johnson Comprehensive Cancer Center, Institute of Urological Oncology, and the Physics and Biology and Medicine graduate program at UCLA. Dr. Calais earned his medical degree and Master of Science degree at the University of Paris in France, and Dr. Calais is a nuclear medicine physician specializing in cancer imaging and theranostics. He conducts investigator-initiated and industry-sponsored clinical trials of targeted molecular imaging and therapy. His goal is to improve the outcome of patients with cancer through theranostic approaches and the application of knowledge gained from preclinical models and clinical studies. Dr. Calais is also an associate editor of the Journal of Nuclear Medicine, a board member of the Correlative Imaging Council of the SNMMI, a committee member of the Prostate Theranostics and Imaging Center of Excellence, and a member of the SWOG Cancer Research Network and advisory board member of the Oncidium Foundation in Belgium. Welcome and thank you for joining us.
Thank you very much for this kind introduction, and thank you for inviting me. It's a great pleasure to have the opportunity to share my experience with Theranostics. I'm going to share my screen. Hopefully it works. You should see the slide, I hope.
Yes,
and my pointer. Very well. So thank you again. My great pleasure to be here and share my experience and my vision of the Theranostics. Today I will focus on the PSMA targeted Theranostics. There are many other targets and other diseases than prostate cancer for which we could use Theranostics approach, but I choose today to really focus on the one that are currently hot after the approval of Pluvicto lutetium PSMA last year. So just to be sure everybody's on the same page, we have a general oncology audience, if I'm correct. So just want to make sure we're all on the same page about what is Theranostics. So in nuclear medicine, we have the PET-CT imaging modality. PET-CT is the use of a radio tracer that you inject in the body, and then you detect the emission of the radiation from the PET radio tracer. You see here various approved and commercially available tracers. And with that, you generate images like this. In the scanner, there is also a CT scan that is associated to it. And then you fused both, then you can have the CT anatomic correlation to the metabolic PET information. What is molecular radiotherapy? It's also named as radionuclide therapy. It is also named as radioligand therapy or radiopharmaceutical therapy. Here, the radiopharmaceutical is injected in a much higher quantity than for imaging, and the physical properties of the radiation are also different. The aim here is to also bind to specific molecular targets But here, instead of emitting positron that can be detected with a scanner, you emit beta radiation that aim at basically induce cell damage, DNA damage, to kill the cancer cells that express the target. I put here the main, again, approved and commercially available radiopharmaceutical therapy agents. You see here how we usually administer these. Basically, it looks like a little bit of chemotherapy outpatient center, patient sit in a chair. You get the injection over a few dozens of minutes, some pre-meds before and after. At the end, patient usually stays, depending on the treatments, between 1 to 2 or 3, 4 hours. We inject it by cycle. Pluvicto is spaced every 6 weeks. I will come back on this later on. And so Theranostics is a concept. It's not really a treatment per se. It's more an approach. It is the combined use of a therapeutic agent, that stands for Thera, and a diagnostic agent, Gnostic, that have both the same molecular target. And so you can have other approach than nuclear medicine to a Theranostics approach, but nuclear medicine is really, because is really one of the best examples for Theranostics approach, because you have both radionuclide isotopes that can treat and radionuclide isotope for scanning and imaging, and both can be bound to ligands that have the same molecular target. I put here the main ones that were previously successfully established as clinically useful. And so it's really an individualized precision medicine approach. The common, sailing message is kind of, you see what you treat what you see. It's really based on the imaging. You can select patients who are more likely to respond better to the therapy, or I think more importantly, patients who are less likely to respond because they do not express the target as sufficiently. So I prefer to say that the PET imaging selection approach is not to select patients, but rather to exclude patients from a potentially not successful therapy. And in prostate cancer, as you are probably all aware now, we have recently approval of PSMA PET imaging agents. The first one was approved in 2020. And last year we had therapy PSMA targeting agents, lutetium-177, PSMA-617, that is called Pluvicto. That's what we're going to talk about today, and look also what may be the short-term future and the advancements we can have in that space. So just coming back and be sure we're all on the same page, we will talk a lot about PSMA. PSMA stands for prostate-specific membrane antigen, and that protein is the protein that is highly overexpressed by most of the prostate cancer cells, and that we use as a target for both imaging and therapy. Today, I'm going to talk mostly about the therapy approach. The registration trial, the pivotal trial that was used for the FDA approval of lutetium PSMA-617 was the VISION trial. The results were out in 2021. I will go and describe the main findings of the trial. It was a multi-center international trial. There were more than 100 sites at the end. More than 800 patients were randomized into a 2-to-1 ratio in favor of lutetium PSMA. The control group was ADT and 1AR targeted agents. At the end, at this time, it was mostly abiraterone or enzalutamide or nothing, versus lutetium PSMA plus ADT or Zytiga and Xtandi. And you can see that initially there were more than 1,100 patients screened, and by PSMA PET scan selection, 30% of them were excluded. I will come back on this later. And here, you probably all know these results. Lutetium PSMA show a great improvement in PSA response rate, in radiographic progression-free survival and in overall survival, more importantly, in comparison to the control group. You can see here the PSA response rates, 46% versus 7% only in the control group. And you see the nice separation of the two curves. Also, very importantly, lutetium PSMA also showed to improve the symptomatic skeletal event-free survival, the quality of life as assessed by the FACT-P total score and the bone pain intensity. And this is very important. That's something I usually like to keep in mind when I have my patients in consultation. And we do observe that, and that's sometimes not really a criteria that is maybe more important than imaging or the PSA response markers. Transitioning to that, I want to put this on the table here. We generated with other groups a score for patient-reported outcome to measure the symptoms and many parameters of patient-reported outcomes specific to radionuclide therapy and more or less specific to PSMA targeted radionuclide therapy. I will go back on that later, but there is salivary gland toxicity, so these symptoms are captured in that score. This is available online. It's a nice way to monitor over time at each cycle how your patients are responding to treatment, how they feel, and I strongly encourage you to use this score as well. So let's go back and look at the FDA label together as it was released in March 2022. So first, the patient population. In the VISION trial, it was mCRPC patients who have been treated prior with at least one AR-targeted agent and a taxane-based chemotherapy. So we are more or less somewhere here in the treatment journey of the prostate cancer patients. So second line or third line mCRPC post-chemotherapy. This is now included in pretty much all guidelines and of course the NCCN guidelines, so very important for insurance coverage. And you can see here it's for patients who were exposed to prior docetaxel and prior novel hormone therapy. Lutetium PSMA is now one option among others. In the VISION trial, and the FDA label followed this scheme of administration, the patient were treated with up to 6 cycles, so it was 4 to 6 cycles. The amount of injected activity was 7.4 gigabecquerel, or another unit is 200 millicurie. And each treatment cycle is spaced from 6 weeks from one to another. And the insurance coverage, by the way, follows that treatment administration scheme. So it's patient will get 6 cycles and probably not more covered by insurances. At the same day, the FDA approval was released for Pluvicto. Novartis got also the approval and of their PSMA PET agent, which is called, the commercial name is Locametz. It's gallium-68 PSMA 11. And in addition to the 2 indications that were prior approved already for other gallium PSMA 11 agents, for example, the Telix kit or the UCLA, UCSF FDA approval, or the DCF-PYL, Pylarify, the other PSMA PET agents, they all share the same indication. So patients with suspected metastasis who are candidate for initial definitive therapy, so initial staging of high-risk prostate cancer patients, basically, patient with suspected recurrent prostate cancer. Here they added specifically the selection for PSMA-targeted therapy. And they released the criteria that were used in the VISION trial to select the patients. I will come back on that later, but that's in the label. Here I put all the PSMA PET agents that are currently commercially available and approved by the FDA. The FDA approval is for a final product, but also for manufacturing process. And because UCLA and UCSF label the gallium-68 on the PSMA level on site, this manufacturing process got its own FDA approval. We were the first to get that. But at the end, this product is the same than this one and the same that this one. It's just the way to get there are slightly different. And that's where there are different FDA approval. This one is different. It's F18 label. It's a different molecule, but it also is a PSMA PET targeting agent. Long story short, I would consider all these PSMA PET agents the same way. They go to PSMA, they emit radiation where PSMA is expressed, and you generate PSMA targeted images from that. There were some concerns initially because the approval of Pluvicto was for patients selected with PSMA 11. And so the PYLARIFY people, and which is the most widely available PSMA PET agent, they were concerned because DCF-PYL or PYLARIFY was not mentioned initially. So very rapidly, there were a lot of expert opinions, guidelines, updates to really say that both PYL and PSMA 11 were deemed adequate for selection to lutetium PSMA therapy. This is in the AUC, this is in the NCCN guidelines. I just want to make sure that we consider both tracer for selection to lutetium PSMA therapy. Let's look now a little bit on how this treatment works and the mechanism of action. So lutetium-177 emits about, for 80%, the beta radiation. That's the one that kills the cell. They travel a few millimeters where it has been emitted, delivering high energy inducing cell damage. But there is also 10 to 15 to 20% of the emission that are gamma radiation. So the gamma is the same thing, for example, than in technetium. And so these radiation, they travel much further. They go out of the body. You can image them and detect them with the conventional scintigraphy camera to generate these types of image. The image you see here is not a PET scan, it's a scintigraphy. It's the scintigraphy, the imaging of the treatment itself. So here you are able to image where your treatment went into a specific patient. I find it pretty nice. Imagine you have that for all the treatments you give to your patients. You can follow and track where the treatment goes for every patient over time. Pretty nice. You see here an image at 4 hours, 24 hours, 48 hours, and 3 days later. What I want to highlight here to understand the mechanism of action, the half-life of lutetium-177 is about 1 week. So after 1 week, you have only half of the product. The rest has been emitted in the form of radiation. And after probably a month, you have nothing left. So the treatment effect is not when you inject the drug. It takes few weeks. It's the continuous delivery of radiation, these beta radiation over time, that will irradiate slowly and continuously the PSMA expressing cell over time. And you see how initially you have this circulating activity that decreases pretty quickly. All the non-use parts of the lutetium PSMA that is not bound to the prostate cancer cell is excreted through the urine. And so after 24, 48 hours, only remain the lutetium PSMA drug trapped into the cancer lesions. You see the metastasis here, continuously delivering the radiation therapy during the following weeks. So here, for example, for the surrounding people and the radiation safety, there is basically no concern to have anymore. It's only the beta radiation. But, you know, during the first hours, that's where and when we give some radiation safety precautions, advices to patients, because here you have more gamma radiation. So gamma radiation, they're not of very high risk. You know, if you would hug a patient just after the injection of the treatment, and you would stay consecutive hours, for example, sleeping in the same bed, very close, side by side, you will get a little bit of gamma, and, you know, maybe people will get the amount of an X-ray or low-dose CT scan. So it will not really harm the patient, but the the people surrounding, but you don't want to expose to X-rays for nothing if there is no medical needs. But I just want to reiterate these radiation safety general rules, and that's something you can say to patients as well, to really understand that the surrounding people, they are not at risk to be irradiated and get some damage. It's just low dose radiation, the same kind of precaution you would take with an X-ray or CT scan. And the nice thing about Theranostics, again, is that this biodistribution and this specific biodistribution for each patient of the drug, well, you can more or less estimate it with the PSMA PET scan. It's the same target, the PSMA protein imaging that you're doing. And that's the beauty of Theranostics. And you can use this PSMA PET scan to kind of estimate a little bit the effect of your therapy. You see here these 4 patients. They are all patients treated with lutetium PSMA therapy. You can see how different they are. And of course, the drug will have different effects in these patients. So you can use the PSMA PET baseline scan for patient selection. You can use it for personalized estimation of the toxicity side effects. In that patient, I do expect some bone marrow toxicity, not in this one who has lymph node disease only. In that patient, maybe this big rib metastasis is painful. I can expect maybe a little bit of pain flare at the time of the administration. So I try to use that, although it's not a perfect science. These images are visually very striking in terms of showing how the drug might have a different effect because it's a targeted drug. Let's review now the criteria that were used to select patients in the VISION trial. So to be eligible to lutetium PSMA therapy for the VISION trial, patient must have had at least one lesion that has sufficient PSMA expression as assessed by PET imaging. So it was a lesion that has uptake above the liver uptake as assessed by visual analysis. And more importantly, patient must not have any PSMA negative lesion. Negative means equal or below the liver level in a lesion that is sufficiently big and measurable by CT. So more than 1 centimeter mostly, and even 2.5 centimeter in the lymph node, which is a pretty big. This is to take into account the partial volume effects. You're probably aware that in nuclear medicine, when the lesions are too small, you lose the signal intensity. So it doesn't mean the target is not expressed. It doesn't mean there is not enough tracer there. It just means that the camera are not able to detect sufficiently the signal if the lesion is too small. So that's why here there was this size criteria to ensure we had the right spatial resolution of the camera. And if the uptake is low, it means there is low expression. And with these criteria, the screen failure rate was 12.6%. And at the end, 831 patients were included after screening of 1,000 patients. But people question the utility of doing this screening. 12% screen failure is not super high. And we don't know if this patient would have been treated, benefited or not of the treatment. So we tried to answer that question. We identified a data set of patients who were treated with lutetium PSMA before the VISION trial at various sites around the world, mostly from Europe. And we tried to reapply this VISION PET-CT criteria to identify patients who would have failed this criteria. You can see here a patient with low PSMA expression. There is no really visible lesion with uptake above the liver. You can see here a PSMA negative liver lesion, here PSMA negative lung lesion, and here lymph node PSMA negative as well. And in this data set of 300 patients, we were able to find about 30 patients with these PET-CT characteristics. And you can see how their response to therapy is much worse than the one who met the inclusion criteria. And of course, these numbers are very low. But if you try to even get further refinement, it seems that the one with the PSMA negative lesions, so these big PSMA non-expressing lesions, these really seem to be the one that do not respond well to therapy, and this lesion seems to drive the prognosis down under this targeted therapy. To further illustrate that, I like to show that case. This is the case of a patient with multiple liver lesions. Some liver on the left side here, you have the baseline PSMA PET scan. On the right side here, you have the follow-up PSMA PET scan after treatment with 2 cycles of lutetium PSMA therapy. You can see that this liver lesion is highly PSMA expressing, very intense signal here. You see it on the CT. Treatment with 2 cycles, you see a nice decrease in size and disappearance of the signal. So a good response. On the other hand, you see in the same patients, other lesions clearly visible by CT here. There is a tiny one here. No good PSMA signal, so it means low expression at baseline. And you can see that after 2 cycles of treatment with lutetium PSMA therapy, there is a massive increase in size of that lesion. So it questions whether the exposure to a targeted therapy in a non-target expressing lesion enhance and maybe promotes the progression of that clone and that lesion. So that's really the lesions you have to look out for. We try to come up with a new way to select patients. Going over all the slides of the PET scan is good. You can identify this CT lesion, but the MIP, these 3D images generated from the PETs, also give you a lot of information. Right away, in a few seconds, you see what's going on at the patient level. And so we try to use this time not the liver, but the salivary gland, because there is a salivary gland uptake in these patients. And the salivary gland is usually 2 to 3-fold higher than the liver uptake on a normal basis. And we have hypothesized that by using the salivary gland, so a higher threshold for normal uptake, we would better select the patients. We come up with a visual score that is based on the salivary gland uptake. This is a high PSG score, a low PSG score. You see no lesion with high uptake, and this is intermediate. We ask 10 readers across the world to look at 270 patients who were treated with lutetium PSMA therapy and apply this score. And you can see how this score can separate pretty nicely different response profile to the therapy. So I think this can further enhance the patient selection in addition to the vision criteria. This was released early this year. It seems that the patient who respond the best, just more or less following the classical TNM classification, are the one with nodal disease only. So maybe it's a micro environment properties. Bone is maybe more difficult to treat with radiation than soft tissue. Bone is also a more advanced stage than lymph node in the TNM classification. But at the end, these types of patients, they seem to respond the best to the therapy. You can see that in this study, for example, they identified 10 patients where the PSA response rate was 70%. This patient had nodal disease only and no bone metastasis. The best potential of whole body PET imaging is that, first, it's a whole body imaging modality. And so you can extract whole body imaging quantitative parameters. You can estimate the tumor volume at the whole body level, and you can estimate the average SUV, the intensity in all the lesions, which is very different than doing a per lesion analysis. And it is still very time consuming. You need to control these lesions one by one to generate the volumes. Many people, academicians, industry, and companies, they are trying to develop clinically softwares to facilitate and giving some automatic tool to extract these numbers. So I hope this will come to reality and will be widely available. Then we'll be really able to use these parameters. as of now is still a bit time consuming, but they are of great value. For example, in that study, this is in all kind of prostate cancer stages, not only patient treated with lutetium PSMA therapy. You can see how the volume you extract from the PET correlate very nicely with the outcomes. So it just follows a basic rule in medical oncology. The more disease you have in solid tumor, the worse it is, of course. But here you are able to extract a number from that automatically, and it correlates nicely with the outcomes. Here again, that's specific for lutetium PSMA therapy. You can see that patient with high volume disease by PSMA PET scan, they do worse than the patient with a low volume disease when they are treated with lutetium PSMA therapy. So same rule as with mostly every solid tumors. More importantly, and that's because it's a targeted treatment, the level of target expression matters. And the SUV mean, which is different than the single pixel maximum intensity, the SUV max of a single lesion, the SUV mean of the whole body tumor reflects more or less the overall level of target expression at the whole body level. And you can see when it's high, homogeneous, you will have a lot of radiopharmaceutical delivery onto the targets, a lot of probability for radiation damage onto the cells, and patients do better than when the target expression is low. Of course, there is low radiation delivery, or when the target expression is heterogeneous, as you can see here. This was verified in the VISION trial population. You can see that in blue here, these are the patients with the highest SUV at the whole body level. So they have more target express, so more radiopharmaceutical delivery, so more radiation damage induced, and you can see how they do better. These were separated by quartiles here, but I'm not sure we can use these numbers, as fixed threshold. It just indicates that the more target expression you have, the better you respond to this therapy. When we look at multiple parameters that are predictive or prognostic of the response to lutetium PSMA therapy, well, the whole body SUV mean was consistently highly significant with the other more classical ones, such as, of course, the liver involvement or the prior chemotherapy exposure. And we tested 17 parameters for the OS, the PSA progression-free survival, the PSA response rate. You can see how significant it was for all these three outcomes. This model that was based on these 17 parameters was able to individualize two groups of patients, low and high risk. You can see how they separate nicely with a pretty strong difference. These MCRPC patients, more than 2 years of median overall survival versus 7 months. So this tool is now available online. We had a nomogram tool. You enter these parameters, and it generates an individualized estimation of the PSA response rate, the PSA progression-free survival rate at 3 and 6 months, and the overall survival rate at 12 and 18 months. It's available online. You can use it. And, sometime in some patients, it give you further insights and prognostic information to make your decision. Few words about FDG PET. FDG, as you are all well aware, is the glycolytic metabolism. So it shows where the cancer cells are highly active and consume a lot of energy with and it showed the aggressive phenotype in prostate cancer. And what we know is that the lesions that have a mismatch, that are PSMA negative and FDG positive, it's really the aggressive phenotypes. There are some dedifferentiation mechanisms that lead to low PSMA expression, and this will lead to a low radiation dose delivery by the PSMA targeted agents. And whether they are seen at baseline or if they appear during exposure to therapy, they're always a sign of poor prognosis, as you can see here. In Australia, when they had a lot of experience with lutetium PSMA therapy, they use on all patients FDG PET, and they try to chase the one with this mismatched lesion with FDG positive and PSMA negative patterns. So you can see here how the screen failure rate in the trial is higher. It's 28% because you detect more PSMA negative lesions with FDG in comparison, as you remember, with the 13% in the VISION trial. And this leads to usually higher PSA response rate. These patients with a lot of FDG aggressive disease, they intrinsically have a poor prognosis. You can see when you follow them, they do pretty bad over time, whatever treatment you give them. So the take-home message is the eligibility for lutetium PSMA therapy as per the VISION criteria and the FDA label is the absence of the big PSMA negative lesion visible and measurable by CT, and an uptake level of the PSMA lesions above the liver background in the majority of the lesions, I would say, and not in the small lesions. And we have some predictive factors of response that you cannot use, religiously, but it gives you some insight about the potential response profile of your patients. So if a patient has no FDG positive disease, a high whole body SUV, homogeneous target expression, a small tumor volume in the node only, this patient will very likely respond well to the therapy. Let's talk now about therapy response assessment, always very difficult, especially with PET imaging. With PET imaging, you see other information than the anatomic changes. Usually you see earlier changes, so it's good, but it's also complicate things a little bit. So in some cases, it's pretty straightforward, right? You have disappearance of all the lesions. You have the biomarker that is going down. Here you can see a nice decline of PSA. Patient is benefiting by these two tools, biomarkers, and so it's a response. In other cases, you see progression on the scan. You see clearly here all these new lesions appearing, diffuse, and also the PSA increasing the same way. Progression of the disease, pretty straightforward. But in many cases, it's not like that. In many cases, you have a decrease of the overall tumor burden, but you have sometimes appearance of new lesions here and there. The PSA doesn't go always in the same direction than the PSMA PET scan, and so you have this kind of mixed response pattern. So we try to identify what are the most relevant parameters you can identify in a follow-up PSMA PET scan to assess response. Some groups have proposed the PPP criteria, so it's progression on PSMA PET. You can see how these PPP criteria are able to separate pretty nicely response profile, better than the PSA. And what is interesting is that if you take the PSA responding patients, or non-progressing at least, well, you can see that if you reapply the PPP criteria just in these, you still identify a group of patients that have a poor prognosis and you separate them better. And we look in a data set of more than 100 patients that had an interim PET after 2 cycles of lutetium PSMA therapy. They were all whole body segmented, so we could look at the whole body tumor volume changes under treatment. You can see that, of course, when the volume increase, patients have a poor response, and when the volume decrease, they have a better outcome. The appearance of new lesion on the follow-up scan is also of a sign of not good response. But what is interesting is that in this waterfall plot that show the PSMA tumor volume changes, so all these patients have decreasing tumor volume, all these patients have increasing tumor volume. You can see they are all red. It means they pretty much all have new lesions. But in the patient with the decreasing tumor volume, you can see that you still have some patient with new lesion. So this discordant. So we created this score called RECIP, Response Evaluation Criteria in PSMA Imaging. Basically, the RECIP partial response are the one with a decrease in volume, no new lesion. The PD, the progressing one, are an increase in volume with new lesions, and the intermediate or stable are all the other ones with the mixed patterns. And you can see how this separates pretty nicely the response profile to the therapy and the outcome afterwards. We hope that this score will be implemented in more and more trials and more widely available. When you compare it to RECIST, PCWG3, PERSIST, this one was the one with the highest inter-reader agreements. It's mostly because of the tumor segmentation. I want to show here another interesting concept where in many cases, the PSMA PET volume correlates with the PSA. You know, when it's high, the high PSA have high PSMA PET volume. In red here, you have the PSMA PET volume. In blue here is the PSA. You can see the values here. You can see that they pretty much more or less go in the same direction in most of the cases. But in some patients, they're very discordant. In that patient, for example, with very high PSMA PET volume, the PSA was only 2. So pretty striking difference. In this patient, it's the inverse. You have a pretty high PSA, close to 100, whereas the volume of the disease is pretty low. So they do, you know, the PSA production from the prostate cancer cell and the PSMA expression at the surface of the prostate cancer cells. These are two different things, and they don't go always in the same direction. But still, the PSA responses are also usually a good way to assess response in most of the cases. You can see in the VISION trial how the different patterns of PSA response correlate with the outcomes and the response to therapy. Here they're separated with no decline, 0 to 50, 50 to 90, or more than 90% of decline. And of course, when your PSA is going down, it's usually a good sign. Here are various patterns of response by PSA under lutetium PSMA therapy. You have the one that, you know, never go down. They seem to continuously progress. Either you're too late or they're just naturally resistant. You have the one where you do observe an effect, fluctuating PSA. You know, you slow down the rise of the PSA, but it's not really going down. You have the one where you induce an effect, but at some point it progressed after 2, 3, 4 cycles. You have the one that goes straight down and stay there. These are the winners. I would say that this you observe in 10, 15% of the cases. And you have the one where sometimes there is a little bit of flare-up effect, or at least it takes maybe 1 or 2 cycles before you see a response. And so they all represent, you know, kind of the underlying biology of the metastatic disease of your patients with various patterns. When you try to combine this PSA response with the imaging response, we try to do that with the RECIST score. Here, this waterfall plot, this time is not the PSMA tumor volume, it's the PSA changes. So these are the PSA decline, PSA progressions. When you look at the ones that have no PSA response, no PSA 50% decline, well, you can see that by RECIST criteria, you're still able to identify a little subgroup of patients that do benefit from the treatment. These are the green ones. Inversely, if you take the one that are don't have any sign of PSA progression by PCWG criteria, so 25% above the nadir, that's the nadir line here. You take these guys, you see that by PET imaging, you are able to identify a subgroup of patients that really do poorly under lutetium PSMA therapy. So at the end, the combination of the two also is probably the best. I want to make sure also that we know that we cannot compare the SUV when you use different tracers. If you have a baseline PYL and a follow-up PSMA 11 or vice versa, you cannot use the matrix derived from these scanners. You can use the visual assessment somehow, but the numbers, you cannot really rely on them because these are different tracers. There are new concepts where you use the lutetium SPECT imaging, so the gamma scintigraphy images I showed you at the beginning. Some sites now, for example, in Australia, 24 hours after the injection of the treatment, they get the images of the treatment. They use that not for dosimetry, they use that for tumor response assessment. And, once the patient is injected with the drug, there are some radiation you can use to make images, and people sometimes they just don't want to waste that radiation, make images out of it, and it offers the patient to not need to do an additional scan. And you can see how this change on the SPECT CT following the lutetium PSMA therapy administration can also correlate nicely with the outcomes and may be able to give you some guidance to continue or not continue the therapy. In this study, they identified 3 groups of patients with both the SPECT tumor volume response, the PSA response, and they were able to continue the therapy, do treatment holidays when patients were really benefiting, and show pretty nice outcomes with this adaptive management. Few words about dosimetry. So Theranostics is really about visualize the target, visualize the treatment with imaging techniques. And the dosimetry, just to be sure that we're on the same page on that and we understand what it is. You see here images of the same patient over time, treated with the radioactive treatments. You see volume of interest that will collect the number of counts over time. With this, you can generate this curve of the radioactivity over time. And the area under the curve is the number of radiation that has been delivered to this specific area. And this, you can convert it into a dose in gray, like in radiation therapy. And so by doing that with imaging, you can estimate in various areas of interest the amount of radiation dose that has been delivered. It has been shown that, of course, the more radiation dose delivery you have, the more anti-tumor effect you get and better response. Here, for example, in the patient that's from the Australian trial, patient who got less than 10 gray at the whole body level on their tumor load, they have a much lower PSA response than the one that have a higher gray delivery. In this trial that's in the neuroendocrine tumor space, it's not in prostate cancer, they show that the higher dose you give, radiation dose, not the injected activity, the better is the outcome of the patient under lutetium dotatate. Same thing here, but this time it's not the radiation dose, it's the injected activity. You can see that the curve separates not as before, they separate less, but still there is an effect. The more injected activity you give, the more radiation delivery you give. But you can see how it's less linear than here, the separation of the curve, because it's a targeted approach, because there are so many parameters you don't control. Sometimes you inject more, but the patient is bigger, the perfusion parameters are different, the level of expression of the target is different. So it's not because solely you inject more that you get more radiation dose delivery. But still, if you inject not enough, for sure, you will not enough have radiation dose delivery. Some people are even trying to estimate the dosimetry data from the PET imaging only to preclude the need to do this sequential imaging acquisition over days. So they try to feed an AI machine learning, deep learning algorithm with match scans, so to generate, rule from a PET scan to guess how the dosimetry scan would look. I think it's still science fiction, but I just find it nice to put it there and know that some people are working on that. Now, let's try to go a little bit beyond vision. Vision was set up for 6 cycles, but in Europe, for example, they use much more than 6 cycles. In that study, for example, they went to 16, as you can see here. And you can see here after 9 cycles, after 13 cycles, how the continuous response is prolonged in some patients. So maybe in the future, we'll have access to that as well. The treatment sequencing, lutetium PSMA therapy is, as of now, one option in the mCRPC second line, among many others, as you're all aware. And it's unclear what is better to do first, where if you want to hit with the more potent agent first or save it for later as a salvage option. I think some trials would be needed to, see in which order it is best to do the treatment sequencing. In that study, they look at prior exposure to Xofigo, to radium, and chemotherapy before lutetium PSMA therapy. They show that whether you had radium before chemo or chemo before radium, at the end, lutetium PSMA therapy had the same effect, and it was safe to do lutetium PSMA therapy after radium. I personally think that we should do lutetium PSMA therapy before radium. That's the trial from Australia, the therapy trial. Here it was the comparison of lutetium PSMA therapy to cabazitaxel, to Jevtana. You can see how the PSA response rate are much higher in the lutetium PSMA group, but they show the 3-year follow-up outcome, and at the end there was no real overall survival difference. So it's pretty hard to beat chemotherapy, and the head-to-head comparison trial, of course, it's more difficult to show some effect. But at the end, the deterioration-free survival was in favor of lutetium PSMA. Lutetium PSMA, you come one every 6 weeks, every 2 months. So it's very convenient for patients. There is much less side effects. So at the end, for potentially a same outcome benefit, you get a better quality of life and toxicity profile with lutetium PSMA in comparison to cabazitaxel. So I think it should be tried first. What we need to know is that the sequencing, the patient selection, the safety threshold, the treat time interval between cycles, how many cycles we can get, all the criteria for response to continue therapy or not. These are not set up. Everything was derived empirically, and there is still a lot of work to do to improve and refine the use of Pluvicto and the concurrent imaging agents. People are now trying to move earlier the drug. So again, Vision was here, and that's the current FDA approval. I think we're in 2023. By the end of the year, we should have the 3 chemotherapy first trials results from PSMA-4. That's from Novartis, from Splash. I'm sure they will show some positive results. Some people are trying even before the exposure to AR-targeted therapy, and in the hormone-sensitive space, that's PSMA addition. Some people are even trying in the oligometastatic space, and some people even upfront at primary treatments. Here, I'm not sure that lutetium PSMA therapy is really appropriate, but here I think it will be of great use for metastatic prostate cancer patients. I put here the names of the trial that are currently being conducted. Some are already close to enrollment, and maybe at ASCO or ESMO later this year, there will be some results. These are the industry biopharma company that are running these trials in the pre-chemotherapy mCRPC space, Splash, PSMA-4, Eclipse, PSMA addition, hormone sensitive. There is also Telix that have an antibody, so it's another way to deliver the lutetium PSMA. It's not via small molecules, but antibody. PSMA-4, Novartis announced positive results. Point Biopharma show also positive result in the Splash trial. So usually, as with the other drug, when you show effectiveness at a late stage population, usually when you move earlier, you also get some better results. And I think this was recently, they got the fast track designation for lutetium PSMA point. So they seem to be in the right direction. Here it's in the hormone sensitive low volume prostate cancer. Again, here I think it's pretty early. we have to weigh the toxicity versus the benefit, but you can see how lutetium PSMA therapy seems to work as well in low volume hormone sensitive prostate cancer patients as well. Some people even try to do that before surgery. So that was an exploratory trial where they took high-risk patients before surgery. They gave them either 1 or 2 cycles of lutetium PSMA therapy, and they look at the dosimetry and the response. You can see that you never get complete pathologic response. You do get 80% of partial response, even 5% of minimal residual disease, but never 0%. So we'll see how we'll go. I think for sure it gives great scientific data. I'm not sure that it will ever be used as a neoadjuvant therapy, but some people are trying that. And then the challenge is really to overcome the resistance. You do have these patients that never respond to lutetium PSMA therapies for whatever reason, various reasons. I show you these patterns of response where you really have the one that's either never respond or at some point get some resistance mechanism occurring. The main mechanism of resistance are the insufficient radiation dose. So we give radiation, but not enough. And it's because the beta was maybe not sufficient, and there are other radionuclides, such as alpha emitters, that can induce more energy delivery, or the target is not sufficiently expressed, and so there is not enough radiopharmaceutical delivery. The radiosensitivity of the disease or the radiosensitivity of the microenvironment, bone usually respond less, with less probability than the nodes. And of course, the intrinsic radiation sensitivity of the tumor with all the mutational factor and DNA damage response mechanisms. What time is it? 5:47. I could continue to speak like that for a while, but maybe I pause in 5 minutes to have some open questions. Beyond vision, PSMA-617 is the molecule that was used for the vision trial. That's the one from Novartis. The Point Biopharma company is PSMA-INT. They seem to have similar efficacy and toxicity profile, but it would be interesting to compare them and see how they do. J591 is another interesting one. You can see the retention time much higher. So it stays longer with a higher, in a higher quantity. So maybe you can expect higher radiation dose delivery from that. It's an antibody, so it's too big. It doesn't go to the salivary gland, so there is no salivary gland toxicity, but it circulates longer. So in the reticuloendothelial system and the bone marrow, it irradiates more the bone marrow, so you have more bone marrow toxicity. So we'll see how this plays, but Telix acquired the compound. They're running trials now, and this will come to the US pretty soon as well. Alpha versus beta. So again, the alpha radiation, there are alpha particles, in fact. They induce much more double-stranded DNA damage breaks and with a much higher probability. And so by switching from beta to alpha emitters, you can induce much more potent effects, much more higher energy delivered. You can see here these very impressive images, these very impressive waterfall plots in various stages. These were done mostly in South Africa. But you can see also here the salivary gland, how they're disappearing over time because the salivary gland take, for example, a serious hit. So of course you get more anti-tumor efficacy, but you get also more toxicity, which is of concern. So we'll see how this will be integrated into the clinical trial landscape in the US. Many companies are popping up every day. Wall Street is completely crazy about all the alpha targeted therapy now. So it is coming. For example, here that's a new company, Fusion, that acquired one in the US. So there is now one trial in the US where you can get actinium PSMA. You will have the slide, I think, so if you're interested. Terbium is another radionuclide. Terbium this time doesn't emit beta particle or alpha particle, but Auger electron. So the Auger electron are even shorter pathway in the matter, and so they deliver also much higher energy. So maybe it can lead to higher tumor dose. They are trying that in Germany and in Australia. So switching from lutetium to other radionuclide therapy agents with potentially more dose delivery. You can see here various companies having various compounds labeled with various radionuclides at various clinical phase trials. Then you can combine therapy with other systemic therapy agents to further enhance the effect of the treatment. You can use, cocktail when you use alpha and beta at the same time. You can radiosensitize, so using PARP inhibitors or chemotherapy to enhance the effect of radiation. You can use immunotherapy, this time not to enhance the effect of radiation, but the other way around, using radiation to turn, prostate cancer that are immunologically cold into a hot state that will be more sensitive to immunotherapy. You can try to increase the target expression using AR-targeted agents that can modulate the PSMA expression. Some people are trying that. For example, here you can see that when you use in combination lutetium PSMA plus ABI or plus ENZA, it seems that it does better than when you use lutetium PSMA alone. And I do observe that in my patients. And that was confirmed also here in the VISION trial. Here is the trial where they combine Pembro. So they give only one dose of lutetium PSMA, and then they start Pembro. So it's really to use the radiation to modulate the immunologic environment to turn from a cold state to a hot state and enhance the effect of Pembro. It seems to work in some patients. Here are other trials that try to, use this different potential synergistic pathway for combination therapy. And all these are ongoing. And well, I made it in time. That's my last slide. That's my thank you slide. Always tricky. And I'm very happy to take any question and discuss further. Thank you very much.
All right, do we have any questions for Dr. Khaled? All right, sir, seeing no questions, thank you so much for joining us. I know that it's very early or very late, depending on how you want to see it, where you're at, but we definitely appreciate you sharing your time and expertise with us.
Yeah, it was my great pleasure. Again, you can share my email to the attendees. I'm happy to, discuss and take any questions also by email.
All right. Well, thank you so much.
Thank you very much for inviting me. Have a great night. Bye-bye.
All right. Well, thank you guys. We've reached the end of our event. I do have just a couple more slides just to remind everyone to join us for our annual mid-year review, previously known as the ASCO review. It'll be June 24th and registration will open up tomorrow. And we do have 2 more evening speaker series coming up this year. Gynecological oncology on Tuesday, August 22nd, and survivorship on Tuesday, November 7th. So we hope that you guys are able to join us. Have a great night and drive safe.